Hey everyone, welcome back to the Energy Blueprint podcast. I'm your host, Ari Whitten, and today I have with me infectious disease expert Dr. Tom Moorcroft. He is board certified in family medicine and osteopathic manipulative treatment. He's been treating adults and children with chronic bacterial and viral infections for over a decade. He's the former acting president and board member of International Lyme and Associated Diseases Society. He's a member of it's called the International Lyme and Associated Diseases Society, is ILADS, Lyme and Co-Infections Evidence-Based Fundamentals Working Group. He's a reviewer of the ILADS Lyme disease treatment guidelines. He's also a member of the Connecticut PANDAS/PANS Advisory Council, and he's been studying this field of infectious disease for over a decade. So very, very excited to have him on the show to talk about COVID-19, the coronavirus outbreak, and get his take on this. So first of all, just for people who don't know, what the heck is PANDAS/PANS?
Yeah, thanks for having me, Ari. Yeah, it's a mouthful. So it's basically an infection caused or triggered autoimmune encephalitis. So it's a pediatric autoimmune associated neuropsychiatric disorder after streptococcal infection, which, obviously we had to shorten that up. And then that really was an interesting thing because we saw kids with behavioral disorders after they had infections. And it was kind of like OCD and rage and weird regressions. And so after they saw it in strep, they started to break out and they realized a whole bunch of different infections and even toxic exposures could do it. So PANS is sort of a short version where it's like, hey, we're going to look for whatever the cause of this autoimmune neuropsychiatric syndrome is, and we're going to treat that, which I think is a kind of an interesting sort of, way to start talking about what's going on with COVID-19 is we started out thinking we had it nailed with strep, and then we realized we didn't really know what we were talking about. And the truth is actually a much broader picture.
Mm-hmm. So let's jump into COVID-19. And I want to present like maybe a bit of context here. There is a range of opinions among experts about this situation. Mm-hmm. We were just talking before we started recording about the New England Journal of Medicine article that was published a few days ago by Anthony Fauci and a team of other researchers where they're basically saying, hey, the mortality rate from this may have been greatly overestimated, and the real mortality rate may be closer to that of a severe seasonal flu. There's also Stanford professor and world-renowned researcher John Ioannidis, who is basically saying kind of something similar to that effect. He's basically saying like we don't have great data yet, so we can't make really strong conclusions. We're all kind of guessing about what the real numbers are given the limitations of data. It's possible the mortality rate could be on par with the severe seasonal flu. And then there's other people who are basically, especially people on the front lines of this in the ICU and the ER, who are basically saying this is nothing like a flu. We are seeing very severe stuff going on, and this is extremely serious. And anybody who is suggesting that this could be anything similar to a flu is nuts, and they're misleading people and endangering lives by, taking things that lightly. Mortality, estimates range from 10% to 0.2%,
Right.
And then there's widely varying opinions among experts on, how many young, relatively healthy people are being affected. Some people saying they're seeing a lot of young, healthy people in the ICU. Other people saying, hey, this is only really a risk to older people with pre-existing conditions. So given that range, actually one more layer I want to add to this, which is that
one more thing to add on top.
There are people who are drawing very firm conclusions in the general public about which of those opinions is the correct one, is the truth, quote unquote, and then attacking viciously and slinging insults towards anybody who doesn't agree with them. So what is your take on this whole landscape of the seriousness of this pandemic and all those things I just mentioned?
Yeah, I mean, I think the first thing is it's kind of unfortunate that we're at that place, but we kind of like to grab on something that resonates with what we're feeling inside and run with it rather than look for data. And we could see even our early government response is like, it's very unclear, probably because they were just go, hey, I'm focusing on the economy, or I'm focusing on this thing, and so we just grab onto that and kind of miss it. And I think the truth in the end of this is going to end up somewhere in between. From the very beginning of this, I said, I don't think it's going to be as bad as a lot of people think it's going to be, but I think it's going to be a hell of a lot worse than some other people think it's going to be. And what we're seeing is the numbers are all over the place. But Dr. Ioannidis, it was a really interesting conversation, an article that he wrote too, because we're seeing limited data out of small areas. And we also see that data that comes out today in 2 days will be completely different as we have a broader perspective. So I've been tracking, when this first broke in the US, we had like a 3.5 to 4.5% mortality rate. And now our mortality rate's been closer to 1.5%, whereas Italy just keeps going up and up, and they're at presumably 10%. But again, that's the biggest problem that I've seen from the very beginning is we don't understand the width and the breadth of the whole problem. Mm-hmm. And we're kind of asking the correct questions, but we're taking them out of context, because what we have to look at is how we really don't know how many people have this, right? So if the current number of 1 million across the globe have it, and we have a 2.5, 3.5% mortality rate, well, that's pretty bad. But the reality of the situation is there's probably a gazillion more people who have it, and that mortality rate will be a lot less.
I'm so glad you brought that up, because one of the biggest things that seems to be going on from my perspective, and granted, I am not an infectious disease expert, don't claim to be one, but what it seems to me is that testing is very limited. Like, to really have solid data, it seems like we would have had to test a large portion of the population. Mm-hmm. And my understanding of the situation as it is now is probably less than 1% of the US population has actually been tested for this.
Oh, yeah.
Much less than 1%. And then there also, maybe that we can bookmark this to come back to, but there also is questions from what I've seen about the accuracy of the test. Right. So we don't even know whether, if somebody gets tested, how reliable those results are. And then we also have the issue of the fact that something like estimates are, from what I've seen, around 50% of people at least who get this infection may be asymptomatic or have only very mild symptoms. And right. And then the people who are being tested are the ones who are, going to the hospital with severe symptoms. And then the mortality rates that we're drawing from the people being tested are therefore taking the most severe cases and looking at the percentage of people of the most severe cases who are dying, as opposed to the general population.
Right.
If I'm wrong about any of that, please educate.
No, well, you bring up a super important point, is we have a selection bias, right? Because like right now, I've in the last couple of weeks tried to send people for testing, and I have, if I send someone from my private practice for testing, it's very difficult to get. And the hospitals are triaging, and they're selecting out the worst people for testing, which, from a perspective of we have limited test kits available and we need to ration them to the most appropriate people, that makes a lot of sense. However, when we break it out and we try to make a broader population decision, where we talk about epidemiology, it's like we're not trying to pick up every severe case and know what to do with that one person, but we're trying to pick up what's going on in the whole country and the whole world so we can make a decision for the population. Mm-hmm. That's a different story. So we're selecting out mild cases, asymptomatic cases, or minimally symptomatic cases. We're selecting out, like, most of the people I know who are positive with mild symptoms in Connecticut are first responders. So we're saying, hey, we want to test them because they're on the front lines. But now we're doing what you were referring to, is we're not looking at all these people who are mild. And what we're seeing in the research is, two things. One is testing. We're testing for viral replication with genetic tests. So we're actually trying to see, is the virus reproducing in your nose, in your mouth, or if you happen to be in the hospital, down in your lungs, to a point where you're infectious. So we're saying you have the infection. We're not checking who's previously been infected, which would be, hey, maybe I was exposed before. It's possible I have immunity right now. We would need an antibody test for that, which they just this morning, finally announced that we have one, which I'm sure none of us will be able to get for a while. But like, I actually think I probably had this in early February.
I
I
think
had a
I had
flu.
it in January. I thought it
Yeah,
was whooping cough at the time because it was unlike anything I've ever got before in my life. And um, other than when I got mononucleosis in my early 20s, it was the most severe sickness of my life. And I was coughing my lungs out for about 3 weeks and I wasn't able to exercise for a month.
right. Well, and same thing. My wife and I traveled. We came back with our daughter. We came back. I was really sick. My wife was pretty sick, darn sick and close. I've had some pretty cool infections in my life. I've never had anything like that.
Yeah.
And then our daughter, who's 10, nothing. Right.
Yeah.
So it starts to fit the picture. We're in our 40s. She's 10, and then I remember Jill was saying to me, right after I was starting to get better, she's like, I was reading about a bunch of people who are traveling and about a week or a week and a half later, they got sick and it sounded like the flu, but it was worse. And it doesn't affect kids as much as you would expect. So we were like, huh. And then like a week later, COVID-19 exploded,
Right. And
but
just
I
a
would,
quick side note, and this is anecdotal, totally anecdotal, but I have posted in numerous of my groups with thousands of people um, exactly what I just said to you, and there's a huge amount of people instantly responding, saying the exact same thing back in January or February, even December, that they had these exact symptoms, the most severe sickness of their life. Many of these people are even reporting they went to the hospital, got tested for influenza, and it came back negative.
negative. Yep.
And so there, and yet this doesn't fit with sort of the official narrative of when it supposedly emerged out of China. Who knows whether we can believe, you know,
Right.
whatever they're telling us. And it doesn't fit with that narrative. And then there's also people saying, hey, that also doesn't fit with the rise in, the surge in cases that hospitals are seeing now. Which I don't know how to answer that. And well, I'm hoping it doesn't mean that I got some other horrific bug and
Right.
that I now still have to deal with COVID-19.
Well, yeah, it's interesting because I know, we're trying to pull the data and use it as best we can. And we know that there's sort of like a molecular or like a genetic clock a lot of these viruses have. And so you can start to see by tracing the genetics of different, samples, how it's changed. And it does look like the SARS-CoV-2 virus, however it came into humans, because it's very, very similar to bat coronaviruses. And we know that coronaviruses do skip here and there. That's how we get the bad ones. But it looks like it happened like the end of November, middle of November. So we think from the early genetic testing that is true. We also have looked at the mutation rates, and it is mutating like all viruses, but it's not mutating so quickly that we think we're going to have a completely different, COVID-19/20 virus that happens like in May or June. It looks like it's going to be one thing.
Mm-hmm.
So, maybe that's helpful. It is kind of, and this is where the data is hard to interpret because, like you said, there's this massive surge recently. And some of it's, I wonder when we look back on this, because we'll be able to do that and say, well, were all the people who were getting sick and going to the hospital already there? Because we know that in the flu season, our medical system is already bursting at the seams, and we know it just bursts even harder. I remember my days, spending lots of time in the ER and in the critical care unit. People are lined up in the hallway, in flu season. And now we have this, and the question is, are we having more moderately ill people who are aware of the disease rushing to the hospital and flooding the system more than it already would be? Or are we really seeing difference in rates? And like you said, the numbers you look at are different, and it's hard to draw that conclusion.
Right. And I think this is a little bit inflammatory to some people, especially, there's the fact that the people on the front lines who are treating people in the ICU are saying, hey, this is severe. This is not a flu. This is really much more severe than what we normally see.
Right.
Having said that, and that I'm not debating that at all. I'm sure I take their word for it. But I think it's also unreasonable to ignore everything that's known about the placebo effect. And the fact that if you're seeing all over the news and the whole society is being shut down and there's terrible fear and panic and anxiety spreading about this disease, of course, people are also going to be, more likely if they start to have symptoms to want to get tested, to want to go to the hospital to get care. Because of course, if they're starting to experience a cough and cold symptoms or flu symptoms, it's like, I don't want to die from this. I want to go get tested and treated if I need to be. So I think it's totally unreasonable to not assume that there's a lot more people going to hospitals seeking medical care just by virtue of how much publicity this virus is getting.
Yeah. Well, and I think the important part too is we can actually have both of these things be relatively accurate. Like if you're a provider on the front lines and you're in the hospital all day with a deluge of patients. So basically, like, look at it one way. We have, instead of one seasonal flu, we have two seasonal flus. Right? We were already about to burst with one traditionally, right? I mean, so we know if we doubled the rate of seasonal influenza, we would have essentially what looks like a pandemic, right? So I'm not even saying that. Let's just pretend coronavirus is as mild as a seasonal flu. It's going to annihilate the hospital system. We're just not set up for it. We don't have enough ventilators. We don't have enough staff. We don't have enough supplies. So when you're on the front line, even if this turns out to be way, way, way more mild than it looks like it is in the media and with the, you suffering as a provider, and the patients in the hospital are getting less than optimal care because of the sheer number of people. So that's a reality. But what I saw, did you see that viral video from the ICU doc in it's like Weill Cornell Medical Center in New York, where he just talked to his pals, and he said, look, what we do know is if you wash your hands and you don't touch the face until you've washed your hands, we can actually not be spreading this. And so we're talking about aerosol maybe and this thing and that thing, but really it looks like it's respiratory droplets. And unless you're in an enclosed room with somebody, you're relatively safe. And he's like, he used to be scared. Now he's feeling empowered and really good because from his experience with past influenza and this kind of double down influenza / COVID-19 thing, it actually, if you take the right precautions, it's not that bad. That's not to say that they're not overwhelmed, but it's just maybe not as easy to spread as people have made it out to be, or as scary as it needs to be.
Got it. So one of the things that I shared some data on this in a group that we both are a part of recently. And I was actually mainly sharing this data and my analysis of it to basically seek out infectious disease experts such as yourself to basically say, hey, is my analysis of this situation wrong? If it is, like, please educate me, tell me how it's wrong. But this data was on ventilators in the hospital. And it's early data. I'm sure the numbers will change as the months go on, but looking at people who have severe enough symptoms from COVID-19 that they need to be put on ventilators, the data looks unfortunately pretty bad as far as survival rates, with estimates, will be specific from this one meta-analysis. Non-invasive mechanical ventilation had a 92% rate of death, an 8% rate of survival for people that were put on non-invasive mechanical ventilation. For people who were put on invasive mechanical ventilation, the survival rate was 3%. So I'm looking at, and there's some maybe estimates that it might be higher, it might be as high as 20% survival rates. But basically I was looking at this data and saying, like, how much sense does it make for our entire public conversation to be dominated by the shortage of ventilators? If at the end of the day, let's say 250,000 people get sick and severe symptoms from this, it would be the difference between 250,000 people dying versus, let's say, 225,000 people dying, or
Right.
230,000 people dying by a
Well,
generous estimate. And so, in contrast to that, we know that pre-existing conditions like insulin resistance, diabetes, high blood pressure, and cardiovascular disease increase your risk of this by 2 to 3 fold. And
oh
I'm
yeah.
basically saying, like, maybe we should, of course, we should work on the ventilator issue and absolutely save as many lives on that front as possible. But we should also recognize that there's an opportunity here for shifting a lot of this conversation towards also including a focus on nutrition and lifestyle factors, and how people can
Hmm.
reduce their risk of death from this condition by improving their overall health with nutrition and lifestyle.
Yeah, I think there's so many things contained in there, so maybe we can knock them off one at a time. But
Yeah.
the one of the things is, my experience has always been in medicine. It's been very hard to have a conversation with people like, maybe we shouldn't go on a ventilator. You're probably not going to make it. And in the duration of my career, we've gotten much more sort of, I hate to use the word aggressive, but and it's probably the wrong word, but more assertive in saying, hey, look, we've done this a long time. Maybe hospice or end of life is a better thing to do, not only for the system, but really for you as a person. And whenever we get, and that's a hard conversation, because statistically speaking, in the United States, 80% of our lifetime medical expenditure is in the last weeks of our life. So, I mean, and I know those numbers, like, they're astronomical, what it costs to go in the CCU. Now, we're in a different situation because it's a new thing we don't know. And to try to figure out what to do, I looked at the rates. A lot of people have heard about acute respiratory distress syndrome, which is, ARD, which is coming out of having COVID-19. That often is what lands you on a ventilator. And so the problem is with ARDS that's severe in sort of a non-COVID-19 patient, the mortality rate's about 45%. So there is a gap in there, and I wonder what it is going to show in the end with that. But that's an interesting sort of piece. But when everybody's looking at all these big things to do, like the medicines to treat, like the hydroxychloroquine and the chloroquine, and they're talking about how they increase pH and how they help zinc get into the cells better. A lot of people are speculating that children are less impacted by this because their melatonin's really high, and a lot of the way these viruses work are they have these they basically induce inflammation through these particular viroprotein things, and melatonin can counteract that. And melatonin can actually help counteract some of the lung injury from ventilators, but it's presumably all anti-inflammatory. So I go back to, and this is kind of getting into your natural life, supporting health naturally. When this whole thing started, I said we need to do a couple things. And one is we need to wash our hands. We need to stay away from sick people who are coughing on us. And we need to, if we touch a surface, wash our hands, touch our beard or our eyeballs, and that's still what everybody's saying. And the other things I said were, we need to get really good sleep. And if we need help, we need to boost it up through blue blockers and turning off the tablets, turn off the Wi-Fi, use melatonin. We also need to get out in the morning for some sunshine to turn on our melatonin production and to get fresh air.
Mm-hmm.
And we need to eat a really good diet. We need to exercise, and we need to chill out. And I was saying that like back January and February about this in particular, and that still holds true. That's really the we have. We can get zinc from food. We can get melatonin from sunshine. I mean, it's like everything we're trying to do with medicine, people can do at home, by minimal dietary change, and everything else is free.
I have to say how unbelievably good to hear and refreshing it is to hear an infectious disease expert say that. And I posted that kind of analysis, which is basically exactly what you're saying. Basically saying, hey, I must be wrong about this because there's so few infectious disease experts that are out there who are saying anything about vitamin D, about boosting immune health, and and nutrition and lifestyle, and the fact that we know that these pre-existing conditions, which are largely diseases of lifestyle, have a massive influence on your risk of having severe symptoms and dying from this condition. Why is no one talking about that?
Well,
And so I said, I must be missing something, but it's great
crazy,
yeah.
right? Because it's like we talk about, there's two real things there, and I think we should work on both sides. One is we have a virus.
Yeah.
Let's learn about the virus and how to medically address the virus. But the other thing we have is the host. And my goal for myself, my family, my patients, for everybody listening, is that we decide that we are going to become the world's worst viral host possible.
Mm-hmm.
Like we are, it's your chance to optimize your health, because this is the part of the equation that we have a lot of evidence on: lifestyle changes, improving immunity and longevity. And what you do now not only is going to help you get through COVID-19, but it's going to help you moving forward. And let the doctors and the researchers work on this thing.
Mm-hmm.
It's just so important. And then if you look, we talk a lot about the Spanish flu pandemic of 1918. Well, if you look at and I'm an osteopathic physician, so it's nice. We have a long tradition of supporting self-healing, meaning number one is your body's trying to heal. If it's stuck somewhere, I want to help. I want to be a catalyst. I'll use medicine if it helps you get better, but I'm not going to just go, I'm going to take that power away from you. It's your body's job to heal. And if you go back to the Spanish flu, we had a 10-fold decrease in mortality compared to other physicians. And what they said was, if they applied common sense, if you
wait,
were
just
someone
to clarify, relative to other physicians or other
doctors, yeah. So basically, at that point, MDs.
Okay.
And again, there is some bias potentially in these numbers, because a lot of the MDs were serving in World War I overseas, because the osteopaths at that point were not allowed to. So we have some selection bias of data that's really old, and we don't even know how many people that Spanish flu killed. But we saw a dramatic decrease in death rate, and they said a couple things. If you can walk, go outside, get fresh air, and walk. If you can't walk and you're infirm in bed, your family was to open the windows a couple times a day to get you fresh air. And then when you were lying down, they did a pedal pump. They shook the feet back and forth, top to bottom, to move the fluid to help the lymphatic system work better, as if you were bouncing on a rebounder or walking outside or doing some yoga. And they saw that this helped improve outcomes. So this is not something new that you or I invented, or all the functional medicine people said for COVID-19. I mean, we have a long history of this stuff working.
Mm-hmm. Absolutely.
So I just think we should do both.
Yes, 100%. I agree with you. And I think there's something worth emphasizing here, because right now a lot of people are in a state of fear and panic, and basically think the only thing that they can do right now is stay home, kind of lock themselves in their home, minimize their contact with anyone, and basically either sort of just wait for this thing to sort of go away on its own, or wait for a vaccine to be invented that is gonna right. save us all. And I just want, I want to be clear. So asking you to speak to people who are operating in that frame of mind, what's wrong with that position?
I think the first thing is that we have a mindset of fear and illness to start with. I do think that we don't know the right thing to do right now. I do know panic is not it. Being proactive is. And so sort of like we've described the physical distancing a whole bunch of different ways. And I like physical distancing because social distancing suggests we're cut off from everybody, which we should not do.
100%. Yeah.
At the moment, though, I've talked to friends of mine, and it's like they're at home with their kids, and they're going out, and they want to go for a hike. Well, and they go pull up to the parking lot, and there's gazillion cars, and they're like, all right, well, we'll come back at another time. But we go outside, and we run, we ride our bike. My daughter and I take the dogs for a walk. It doesn't mean you have to be confined to your house.
Mm-hmm.
And,
Assuming
at
you're
the
not living
moment,
in a place that's like truly under lockdown, as some people are. Like I have some
well,
friends in
that's
Puerto
true.
Rico, and I think in the UK, lockdowns
Yeah,
are a lot more strict.
don't break the law. It's interesting though. I was looking at the data in the UK though, because they basically said, let's go for herd immunity, which right out of the gate, that's probably not the best idea, because you need to get like 65% of the population infected
Mm.
in order for it to potentially work. But their numbers are today, now granted, they're a little behind us, but they're not looking all that drastically different in terms of their trajectory. But I will caution everybody, like a couple of weeks ago, we had 1,600 cases in the US, and now we have a gazillion, so it is rapidly changing. But I think that we should follow the rules. But like a lot of experts have been talking, we need to make a decision in the next couple of weeks. We can't keep doing this forever. And we're hoping that there's a seasonal variation in this, just like there is in the flu. I don't know that that's going to happen. That would give us more time. But I do think that we need to be having a conversation where the public is demanding more testing, but particularly antibody testing, so we know who could be immune. And then once we know who those people are, we could figure out if they actually are immune. That way, say, like, let's say you and I actually had it, then we would be, and we confirm we're immune, then we would be safe to go back out into the workforce, and we could start let more people go out. And we could say, hey, kids are safe, people are immune, have been exposed, are safe. Now maybe some of our higher risk population, we can isolate them. Because if you look at what they did in Singapore and Taiwan, they did early testing, they did early isolation of those who were infected, and early contact tracing, meaning if I had it and I was in touch with 10 people, they would check if those people were sick and maybe quarantine them. And they really just nipped it right in the bud. Whereas the problem that we're in right now is we didn't act decisively in the beginning, and there's a lot of mixed messages. So right now we're kind of stuck in doing this, and I just think we know that the flattening the curve conversation is going to help the load at the hospital, but it's not going to stop the total number of people getting it. It's just going to spread it out over time.
That's such an important point. I just want to emphasize is I think there's a lot of people who are kind of, there's been so much of the message around flatten the curve, which is a very useful endeavor that absolutely will help minimize deaths due to lack of being able to receive treatment at the hospital. But there's a lot of people, I think, who are confusing that objective with, by doing that, the virus will go away.
Right. Yeah, it's probably not going to happen. It's literally just figuring out how many people per unit of time are going to be in need of care. The other thing is flattening the curve could potentially help us if there's a seasonal variation, meaning going into the summer, we get a reprieve, but likely it'll just shift to the southern hemisphere and come back up like influenza. So the question is, what do we do then? But at least we would have time. And, we don't know the answers. And I think that the truth really lies between everybody just go back out into the world and let's just see what happens and stay on lockdown forever. And again, it's hard because I don't have the influence over the industry to make antibody testing. I know we need more PCR. I mean, even today, as of last night, we had only done 180,000 tests in the United States, which I think is crazy because we actually have more cases reported than we've done testing. So some cases are presumed positive.
Right.
So
I almost want to go on a tangent there of digging into the data, but how much of the rise in the number of cases can we really say this is solid data giving us a really good picture of how fast this is spreading, or how much of it is just a function of, as you said, that we're presuming many cases
more,
and just the simple fact of we're testing more people. So the cases, the number of cases that are being reported every day are going to skyrocket just by virtue of testing tons more people every day. Like, how can we discern out what is the actual rate of how fast this is spreading given those limitations of the data?
Yeah, it's a tough question because you're definitely going to see a rise in positives because you've done the testing and you're just accounting for more truly positive people. And what's going to be really interesting is when this is sort of when we get through the acute phases of this and we start to look at antibodies and who's been exposed, the number of total people exposed will be most likely astronomical compared to those who are confirmed during illness. So the current testing is looking at who's infectious right now. And we know that most people are, from the time of exposure to the time that they're sick, are getting sick within about 5 days, and a little sooner, a little later, but around 5 days. So we also know that there is asymptomatic spread, and we know that the highest amount of virus found in samples are people in the first 5 to 7 days. So typically before you're sick, you show symptoms, or when you're mildly sick. So if you go on to have severe disease, you're more likely to spread it to the people in the hospital because everybody's over top of you. But realistically, your viral load is actually lower than early in the infection. So our numbers are going to be hard to interpret because we have to say, it's almost like you have to set up and say, what's the ratio of testing availability, compared to number of people tested and then reports. And we're so far behind. And that really, but the problem is the numbers that we're seeing are representing people who are actively infected. Mm-hmm. So, but again, how many people are the numbers? Like if you look at influenza, we're going to have 35 to 60 million people in the United States every year have it, with 30 to 50,000 deaths, which is a lot of people. But we're talking a couple thousand deaths at this point, and in the U.S. from this. It's hard to say.
What percentage of those? How many millions did you say get influenza every year?
Like 35 to 50, depending. Sometimes 60 even per year.
So 30 to 50 million, 30 to 60 million per year get it. Roughly, let's say 30 to 50,000 people die from it.
Right. And so it's like a 0.1% mortality.
Right. And then there's this other figure, which is the percentage of those 30 to 50 million that would seek medical care, which is, I'm guessing maybe 5-10%, something like that, maybe 15%.
Yeah, something like that. I mean, medical visits, I think last year were about 16.5 million. I have the CDC up, and we estimate overall there were 35.5 million last year. So, a little less than half. But hospitalizations are under 500,000, even though we had like 16.5 million people seek medical care for it.
Mm-hmm. Got it. Okay, so you were talking about this a minute ago. I want to come back to it. I think it's an important point, which is there's a discussion as it pertains to solutions to this. I mean, we're already operating in one solution, which is shut down the entire economy, everybody stay at home. And that is the solution we are operating in currently. There are people who think that's a bad solution, and there are people who are suggesting other potential solutions. Some people, obviously, the extreme is like everybody should just go back to work. This is nothing more than a flu. More detailed and specific suggestions are we should not be shutting down the entire economy. We should be protecting those at risk of getting severe symptoms or dying, and we should have only a very partial shutdown of the economy and allow people who are not at risk for severe symptoms to get back to work, and various nuances to that. But there's this dichotomy that's being presented, which is lives versus money, which is we either say, hey, we are concerned about this. This is killing people. This pandemic, this infection is killing people. We need to save as many lives as possible by shutting down the entire economy.
Right.
And to be concerned about money and the economy is nonsense. We need to save lives, right?
Right.
Well, there's this other aspect of that discussion, which is really important, which is, and I'll quote David Katz here, who's the head of Yale's Prevention Research Center. He said, the unemployment, impoverishment, and despair from the job loss, bankruptcy, tens of millions of people losing jobs, tens of thousands or hundreds of thousands of businesses going bankrupt that are likely to result from this economic shutdown will be public health scourges of the first order. And I'll also mention there's actually research showing, how the unemployment rate links with increased risk of all-cause mortality. This has been quantified in numerous studies, and Political economist Toby Rogers says, he calls them deaths of despair, and they include heart attacks, suicide, alcoholism, homicide, mental health, and prison issues. There are widespread health problems and death that result from economic shutdown. And I don't think that it makes sense to just say it's lives versus just money. No, that the economic shutdown costs lives as well.
Yeah, well, it's interesting. I mean, if unfortunately, the group of people you just mentioned are disproportionately hit from the economy turning down. It's like the upper echelon. I mean, they're good for a long time. It's like, it's unfortunately the people who are most at risk of all these conditions are the ones who are going to be hit the hardest. And the people who are having a hard time, paying for food or making their rent or whatever are going to be the ones who are worse. And I know a lot of working moms who, their daycares are shut down. So they feel they can go there, maybe like even people who work for me. I mean, we can have them work, but they can't because they don't have childcare anymore.
Mm-hmm.
At least in Connecticut, they're doing some stimulus there and covering some of that bill. But in the long run, the state of Connecticut and the government of the United States are not going to be able to foot the bill for every single person not going to work, because our tax are what's paying that. And I'm not an economist, but what I do know is that kids are relatively safe in this. And when you look at the data, I mean, it's people 55, 60 and over are still the highest risk groups. And we also know that like 3 or more medical conditions pre-existing, especially like you were saying, lifestyle, these are all lifestyle diseases, for the most part, are super high risk. 2, not so much, 1 a little less. But the mortality rate and the morbidity, the severe sort of outcomes shy of death from this in a group that have no pre-existing medical conditions is infinitesimally small. It's less than 1% in most studies, sometimes 1 or 2%. But I mean, so the risk to a lot of us is low. Now, with that said, there are also people who are at higher, it's almost like a vaccine conversation with people who don't want to get vaccinated, which is a whole nother thing. I'm probably going to have people throwing stuff at me, but is a lot of it, like, regardless if you want to get a vaccination or not get a vaccination, like my daughter, they wanted to give her a hepatitis B in the first 12 hours of life. I'm like, she has no risk of exposure to hepatitis B until at least she goes to sleepaway camp based upon what we do in our lives. So it's an exposure risk. So first responders, people working at the hospital, obviously they have a different risk than someone working at the grocery store, possibly, or someone working at an accounting office. So I do think that we need to really get some data that's a little more global and broad, because like you look at the data coming out of Iceland, I mean, their rates of infection across their entire population, because they randomly selected people who weren't sick to be included. So we should do some of that random testing people have recommended. Then we would have a better idea, because there's no doubt that a lot of what I saw in the ER, in my ER days, we talk all the time about social admissions. Because you have to keep people around because they're not safe to go home, but they don't really need to be in the hospital. But it's because their social situation doesn't allow them to be safe and healthy, not because they currently have a medical problem. But if I send you home tonight, you'll be back next week really severely ill or dead. And so it is a significant concern that I'm not going to have the answer to for the whole country, but I do think that, like we've been talking, the answer is somewhere in between full lockdown and then just like everybody run to the store and go back to work. And maybe, who knows, maybe the answer is everybody can go back to work. But the data is just sort of unclear at this point.
Right. What about vaccines coming to save us? And I'll mention, do you know who Paul Offit is?
Yeah.
Okay. So Paul Offit, for people listening, is I would say he's maybe the face of the pro-vaccine movement. He's the most staunch pro-vaccine person you could possibly ever imagine. He's an author of textbooks, medical textbooks on vaccines, and owns a patent on vaccine, makes money off vaccines, if I remember correctly, is aligned with pharmaceutical companies and so on. Not saying he's a bad guy. I'm just trying to say the facts here.
And give his background because it's important.
Yeah.
For this.
Or, I mean, from some people's perspective, that's all of that stuff is he's doing the most amazing public service in the world. And that's, he's a boon to humanity for all of those things. So depends on where you're polarized on that spectrum of the whole vaccine issue. But I saw an interview with him a few days ago where he was talking about a potential coronavirus vaccine. And I believe he himself said that he would not take it. If it came out, because in order for a vaccine to be released into the public, it needs to have years of safety testing on it first. So I hear some people in the public conversation who are like, well, if we just stay in our homes for a few more weeks, they're going to have a vaccine. And it just seems to be wildly misguided thinking that it's just not realistic.
Yeah, and I heard the same thing. I mean, I think vaccine develop. If it saw the same information interview that you did, it was like 5 or 6 years would be fast.
Right.
And so a lot of people have been throwing around, hey, 14 months will be really fast. I mean, the problem with fast tracking any of this is kind of like what's happened. We see that we overshoot, we undershoot, whether it's safety or efficacy and toxicity. I mean, we don't know. We've made so many errors around this SARS-CoV-2 outbreak that you could just go, hey, and people are losing money over this thing. Now think about a vaccine where people are going to make money. And they're trying to help people. And you're just going to dive into this whole scenario where if you rush it, you could potentially kill more people than you actually were going to get harmed by the virus. Now, I think that there's no doubt that some vaccinations are helping the right and from a public health perspective. And that's always the problem, is the public health versus the individual. And they don't always meet in the middle nicely, right? I mean, but I think that if we rush this to market, it's going to be it's going to be dangerous. And I've looked at you review the different types of vaccines, and they're actually one company that's really at the front of this is making one that's based on a model of messenger RNA. So they're basically trying to take the genetics and stimulate your body to make antibodies to the virus. They've done this successfully in animals in other things. They've never been able to successfully do it in humans in all the previous testing, yet this is our best option at the moment. It's like, how does it go to the front, when we have other more tried and true methods, but this way could be faster. And all of a sudden, because we're panicked and I just remembered something. My daughter, when this all started, when I started to try to preach calm, she said, Daddy, we need to all remain calm. Because if our brains are going crazy, we can't think rationally or scientifically. And I was like, she's 10. And I was like, it's exactly it. Because if we go, oh, this vaccine is the best choice because we could make it go the fastest.
Right.
To market. That doesn't make sound scientific or medical sense.
Yeah. I believe, you may know more about this than I do, but I believe I read something about a vaccine for coronavirus that was tested in an animal model that actually showed worse outcomes when the animals were exposed to the coronavirus after being vaccinated. Have you seen that?
I didn't read it. I did hear something about it, but I haven't followed up on that particular one.
Okay. And I think maybe even Paul Offit mentioned that in the interview. Maybe that's where I'm remembering it from. But I mean,
it's Ari, you just reminded me of something really important too, is there's so much information being disseminated now because of the internet and social media. It is next to impossible to keep up on everything. And one of the things that I've heard, I got one of my staff members who's also in physician assistant school was reading a paper from a website, it has all these references, and they sent this, it's just so long and there's so much cool information. I was like, and I was reading it and they're saying, well, SARS-CoV-1 and SARS-CoV-2 are similar this way. And then they put a line, this is why SARS-CoV-2 is worse. Mm. And they never actually said anything different. They said they're the same, but it might be worse. And they have all these references that have nothing to do with coronavirus. They're like, but they reference what the statement was, but completely out of context. And we're getting inundated as consumers of information with tons of information that's not always corroborated by the actual science. And then you look at some of the other docs we've talked about, like our friend from Stanford, and he's well known for saying, hey, you have to actually read the clinical trial and know what's in it and what it really means. And we take a lot of times, I remember when I was reviewing some Lyme treatment guidelines, there was a paper written in 1996 or so that said one particular infection would persist after short and long-term courses of treatment. And in the year 2000, it was used by that author who wrote the previous paper in a different guideline to prove that we shouldn't use longer-term treatments because that's not been proven to work. So they came to with completely different conclusions, and they just said, oh, this sounds good, let's plug it in there. And unless you go and read it, so it's just, we have to be aware that so much of this can be sensationalized. And it's, when we finally, and we're also in the middle of it. So we're getting a bunch of data today that is going to be evolving for months or years. And so you just can't draw big conclusions necessarily.
Yeah. I want to touch on one other aspect of the vaccine issue, which is if we look at the flu as a guide for what potentially the potential scenario we can have here, the flu has been around for decades, or more, I guess maybe a century and beyond. I don't know how similar genetically the strains are going back 100 years, but this has been around for decades. The flu vaccine has been around for, I don't know how many years or decades. Do you know?
Not exactly. It's been my whole career.
Okay. So it's been around for
at least before 95. I know it's a long time.
Okay. So at least 25 years or so. So yet every year we have a flu vaccine, and because the flu virus mutates every year, it's a new strain, the flu vaccine often has very limited effectiveness of often between like 30 to 60%, or maybe the range is like 30 to 80%, depending on the year. But often there are many years where it's and correct me if I'm wrong, but my understanding is it's not very effective at all. And and it seems to be, given that we've had decades to do that, it seems unlikely that within the span of a few months, we're going to develop a really effective vaccine for this other virus that, may be also mutating into new strains. But that's my understanding as a non-infectious disease expert. I'm curious what you're saying.
Right. Well, I think your understanding is pretty good. And I've heard some good numbers like up to 80%. And I've heard some bad numbers like 10 to 20% efficacy. Although I think the data really does show it's somewhere in the middle, like your numbers. But the problem is, like you point out, is the virus mutates. And if you step back and we look at common cold, we don't have a vaccine for the common cold because about a third of it's caused by 4 coronaviruses, and the rest of them are typically rhinoviruses, but they mutate every season, sometimes, and sometimes in the same season. And so, we can't really keep up with it, but we just say, hey, some people, it's been around for a long time, so we'll just let it mutate, and we can't stay ahead of it. Mm-hmm. So we're just going to say, oh, you got a cold, and a few will get sick and die, but most of us will just have a cold. Mm-hmm. The thing with this novel coronavirus is we're not sure what's going to happen. It's already mutating. Like I said, it's kind of mutating sort of slow. But the original, what they're calling SARS Classic now, the original SARS from like 2003, people who were exposed to that have shown immunity for over a decade after exposure, whereas some of the other viruses, people, it might be a couple months to a year or two. We're kind of hoping that people, at a minimum with this current virus, we're going to get immunity that would last a year and a half, or at the very least, the genetic variation from one season to the next, if it does truly stick around, will be that the next year we won't get as much. We'll have some memory of it. It'll be close enough that instead of having a moderate to severe disease, we might only have a mild disease if we're exposed. So really what's going to end up happening is we're going to potentially design several vaccines trying to chase the genetics of this. And then by the time we actually can get to market with it, then we're going to have to continually modify it.
It may, by the time we get to market with it, it may very well be a situation just like the flu, where we're guessing as to the strain and how effective the vaccine will actually be.
Yeah, definitely.
But without the years of safety testing.
Well, right. And so basically what we're going to end up having to do, if it's like the influenza vaccine, is make sure the basic aspects of this vaccination are safe, and do all that kind of testing, which will take years. And then we're going to have to do it just like the flu is one scenario. The other scenario is this whole thing just burns itself out, like SARS did. And we don't really see it. We still can, maybe people be immune for 20 years. And because everybody gets immune, the virus burns itself out. It doesn't look like it'll be like that. But again, we're not sure. I mean, and the problem is when we look at the original SARS virus, that was very lethal and a very small group of people who got it, and it was more of a discrete thing. This almost looks like just a second seasonal flu, so who knows where it's going to be in the end. And any big predictions today on what it's going to look like in a year or two are probably going to be wrong.
Yeah. So what do you think is should be the big takeaways for people listening to this? And by the way, I think this has been for me, I found this to be a fascinating and enlightening discussion, and I'm loving this conversation. Thank you for sharing your wisdom. What do you think, the big takeaways that you want to leave people with, especially for people who are just kind of feeling like they should just lock themselves at home and wait for a vaccine or wait for a drug to come, or on the other end of the spectrum, people who think, oh, this is just like the flu and we should just go about business as usual. What do you want to be the big takeaways from this conversation for everyone listening?
Yeah. And thanks for having me too. This has been a blast. And, it's just so nice to be able to share, not only your expertise and years of training, but it's like my passion, because I think the important part here is that I say to people all the time, if you think you have COVID-19, the very first thing you should do, take a deep breath and relax. Then call your doctor's office and don't panic, right? For a whole bunch of reasons. But I do think we need to put it in perspective. We still know the number of 80 to 85% of people are going to have mild disease, if they even get it, is still holding. And we also know that another 10 to 15% are going to feel worse than they would like to, but they're going to have no issue. And less than 5% of people who get this are going to be really sick. So whenever I have these conversations, it's interesting. I was talking to Alan Christensen the other day about this stuff too. And I'm always like, hey, the hospital person versus the person out in public. Well, and he's like, somebody just told me this. There's vertical people and there's horizontal people. And we're talking, a lot of what we hear in the media are about horizontal people who are gravely ill in the hospital. The vast majority of us are vertical. Mm-hmm. So let's stay that way. So that I still think that for the next at least couple weeks, hopefully 2, not more, much more, we should let the scientists and the researchers sort of sort through the data. Mm-hmm. But we have to make a decision soon. I mean, we can't, we just missed the end of ski season, basically, and I'm kind of frustrated by that. And my whole family is like,
reason than the ski season.
Right. I mean, like I need to move so that I can just go skinning or something, when nobody else is on the hill. But no, but in all seriousness, I think that we need to remember that the doctors on the front lines are telling us good personal hygiene is important. If you are coughing, that's when you put a mask on. Those are just easy things. You don't have, that's common sense, right? How would you protect yourself from the flu? And then outside of all of that, take all the data with a grain of salt and watch it over time, right? Because we've seen that it changes every minute. So calm down with that. But as we know from our functional medicine practitioners, we know from osteopaths from the Spanish flu epidemic, we've got those two pieces. We've got the virus and we've got people working on that, and we have you. And so most importantly, I would suggested everyone take a moment to figure out what they can do to make themselves the best, healthiest version of themselves so that the virus can't take hold in you. And a lot of the
such an important point that, like, I think there's a lot of people, as I said, who are not taking advantage of this window of time right now, where they're at home, where they're potentially waiting within weeks or months to be exposed to this thing, and they're not taking advantage of it to create their best health by optimizing nutrition and lifestyle factors that we know directly relate to your risk of getting severe symptoms or dying from this thing. And
if there's anything that we know about coronavirus is the more lifestyle illnesses you have, the worse it is. If you're a smoker, stop smoking. I mean, I think it was Patricia Arquette was doing that. It was either Twitter or Instagram thing where she's like, I went cold turkey and I'm dying. So everybody who wants to suffer with me, quit cold turkey and we'll be here for you every day.
That's great.
Right? You know, vaping, stop it. It's ridiculous. We know enough that it puts your lungs at risk. Anything that you can do that will help your lungs be healthier, like fresh air, exercise, and not vaping or smoking will help. This is lifestyle stuff. One of the things really interesting too, Ari, and I'm glad we kind of tangented a little to this piece, is a lot of what we're doing in our research is looking for medicines to do things, but some of the medicines work because they improve zinc into cells. Well, we can do that by eating good food and optimizing our gut health. Mm-hmm. We look at, it's interesting when you look at melatonin and these inflammasomes, well, we can optimize our melatonin by getting up and getting sunshine and then going to bed on time and creating a dark environment early in the evening. But
worth mentioning on that point, there's research, this is an area of my expertise, so I can't help myself, but there's research showing that standard room lighting in one's home at night suppresses melatonin levels by over 70%. So people are up. We know melatonin is really important. We know our brains produce melatonin or should be producing lots of melatonin every night. And yet most of us have lifestyle habits that, you know, we're in front of screens, we're in indoor house without blue blockers on, and are suppressing our normal production of this very important hormone that decreases our risk of severe symptoms by upwards of 50, 70% in most cases.
It's interesting because I'm sitting here at my desk and I've got my early evening blue blockers, my late evening
nice.
You have to.
Yeah.
Now, what was really interesting too is we're in a society where we look for the magic bullet and the magic cell. I'm like, look, you don't make melatonin well unless you get up in the morning and get sunshine, and you don't release it unless you turn the damn lights off.
100%.
And I 100% agree with what you're just saying. The other part that's really interesting is some of those inflammasomes that everybody's looking into, maybe melatonin helps against, because there's a lot of science behind that. Nitric oxide also can inhibit the activation of these inflammatory mediators in the body. So then I'm like, oh, well, how? What do I know about nitric oxide? Well, it's mostly made in our nasal sinuses, so the sinuses around your eyes and your nose. Well, what do I know about that? I know that if we do certain types of breathing, such as like Wim Hof breathing or the Buteyko breathing method, not only do I open up my nasal passages, which just as an aside, helps brain detoxification, so you can think better and ward off dementia, but also now we have more nitric oxide, which then can decrease inflammation. Then you look at vitamin C.
Just real quick on nitric oxide.
Yeah.
Sunlight, exercise, green leafy vegetables, all powerful promoters of nitric oxide production.
And so this is, and then even ascorbic acid dose dependently inhibits these particular inflammasomes that are triggered by COVID-19 and are fixed by all these things we've been talking about, or diminished. So we don't know that doing any of these things actually, will make COVID-19 not happen to you or make it not as bad, but think about the people who are getting sick. It's all the people who choose not to do these things. And so my biggest recommendation for people, and one piece about the breathing and stuff, I love throwing out the breathing because whenever you breathe on a regular basis in a way that is you're conscious, you then start to get more parasympathetic. You get your vagus nerve tuned up, your gut calms down, and that boosts your immune system. And it just takes you out of that fight or flight. So you have a better chance to make good decisions, like my daughter pointed out. And really, all of these little simple things aren't that hard to get some. I mean, exercise is going to help you become more parasympathetic. And then I think about, intermittent fasting can promote cellular recycling, like autophagy, we call it. Well, that's also a great way to get at intracellular pathogens. But exercise changes some of the levels that will trigger that as well. So it's not just you have to intermittent fast. There's a lot of ways to naturally promote health. And so I'm telling everyone, pick one thing that you've heard us talk about that you will do and commit to do for the next 7 days. Because almost everything I've seen where people will do it, whether it's breathing, EFT tapping, sunlight, if you do it for 7 days, we can measure immune markers that are changed, and for the good. And once you make it a habit, then you can start to say, hey, wow, you know what? I went for a walk 15 minutes every day for a week. Now it's day 8, and I'm like, oh, I'm going for a walk, and it's just like, and then that's how I learned about natural health. I was in regular medical school, knew nothing about it. I felt like crap. And I started doing yoga because somebody shared me a DVD, and I just got into it because it calmed my brain down. And the more and more I did it, then I was like, oh, I don't drink soda anymore. Oh, I don't process foods. I don't eat them anymore. Why is that? Then I started researching, and I was like, oh, my body is smarter than my brain. So yeah, just get out there. I'm warning people, or suggesting that they don't try to do everything. They just take 1 or 2 things that they commit to doing and do it.
Mm-hmm. Beautiful. Dr. Moorcroft, this has been phenomenal. This is honestly one of my favorite interviews I've ever done. And it's such an important and timely, urgent message to get out. I'm recording this on Friday, April 3rd. Normally I record podcasts weeks in advance, give my team time to prepare them and get the transcript and proofread the transcript and get the page up and the graphics and all that stuff. I'm actually going to rush this and get it out tomorrow, because I think that this is such an important message. My team's going to be pretty pissed off at me, to be honest, when I tell them they've got 12 hours to do this. But this is just phenomenal. Thank you so much for coming on the show, sharing your wisdom. I really appreciate it. And I really appreciate how knowledgeable and how sensible you are and detailed in your analysis of all the nuance of this very, very complex issue. Really, really appreciate it. Thank you so much for coming on the show.
Thanks for having me. Appreciate it.
Yeah. One last thing. If people want to follow your work or work with you or get in touch with you or whatever you'd like to say as, how the best way people can sort of follow your work, let us know how to do that.
Awesome. Yeah. So best way to find me is at our website. It's originsofhealth.com. So plural origins. And if you put a /coronavirus there, I have a coronavirus resource page. I've got some downloads. We did a live mini summit with other experts. We're actually going to be doing a 3-night mini series coming up starting next week. Totally free. So that'll be a great resource, hopefully, for people. And certainly over on Facebook, I do a ton. So nice and simple, Origins of Health, or they can check me out on Instagram, DRTOM Moorcroft. And so I just appreciate it. And I'll throw one last thing out there, because I think that it's so important for people to understand how much power they have by making small decisions. And I see so many adults, and right now a lot of us are home with our kids. Remember to lead by example, because you have so much influence over your family members and your children, even your teenage children who are telling you that they don't want to hear from you, they hate you or whatever. They are looking to you. And if you are leading in your neighborhood, your family, and your circle of friends here, remaining calm and just doing like we did. We had a conversation about what we know is truth. It'll all come together. So help other people remain calm, and definitely realize you have all that influence over everyone.
Beautiful message. Thank you so much, my friend. And I hope to do this again with you. Hey there, this is Ari again. One more quick thing before you go. Just make sure to subscribe to our YouTube channel, the Energy Blueprint And also make sure to subscribe to this podcast on your favorite podcast platform, whether that's iTunes or Stitcher or anything else. I hope you guys enjoyed this interview, and I will see you again next week.